Good morning. Good morning, everyone. Here with Ramya, I am introducing Dr. Ramya Madam. Madam is a very good academician, now working as an assistant professor at JIPMER, Puducherry. Madam did his MBBS at Tirunelveli Medical College, post-graduation at Trivandrum Government Medical College.
My topic is about updates in labor analgesia. I don't know how far your knowledge about anesthesia, especially over labor analgesia. Pain has been, for especially during labor analgesia, is always a myths and controversies over the centuries. So to take forth, these are the two pioneers who put forth the labor analgesia towards the world. First one is the James Young Simpson, who introduced a labor analgesia during the starting of 18th century in the form of chloroform to a woman who had an abnormal pelvic. Followed by him, James Snow, who introduced chloroform anesthesia to Queen Victoria for his delivery of the 8th child. So then only the labor analgesia has come to the world, and the field has been revolutionized a lot. So do we really need labor analgesia, or do we really need to address this labor pain? Because we may think that our mothers, grandmothers and great-grandmothers have undergone this labor process normally. They have never gone through this pain management and all. Let me discuss about that. So way back in 1971, McGill University had put forth a pain index rating scale. In that scale, they found that this childbirth pain, that means the labor pain, has found to be the second severe most pain among all of the pain. And especially this primigravidas experience more pain compared to that of the multigravidas. Next, do this pain has really an effect on the mother and fetus? The answer is yes. Because during a pain, many sympathetic stimulation occurs. This will cause us a rise in the BP, heart rate, and many sympathetic changes can occur. All these changes may be tolerated by a normal pregnant woman, but this might be deleterious to a woman who is already having a compromised cardiovascular system, or a mother who is having a hypertension during the pregnancy. And if we take the fetal side, all these changes causes a vasoconstriction leading to a fetal metabolic acidosis and fetal hypoxia. So when we look back to the question, do we really need to address the labor pain? The answer is yes. One thing, because the severity of the pain is higher, and the second, the effect of pain has more adverse effects on the mother and fetus. So this labor have to be addressed with the pain management. So before knowing about the techniques of anesthesia, we have to have some knowledge about the pain transmission during the labor. So we all know that we have two stages in labor. One is the first stage and the second stage. So during first stage of labor, the pain is usually a dull aching, and mainly it is of visceral in nature. The pain occurs mainly because of the contraction of the uterus and the lower uterine segments and cervical regions. So this is transmitted mainly by the T1 to L1 fibers. And during a second stage of labor, the pain is really sharp and intense. It is mainly due to the somatic pain which arises because of the stretching of the perineum. But the transmission of this pain is from the S2 to S4 segments. So whenever you consider a technique for a labor analgesia, your technique should cover from T10 to S4, from your lower thoracic segment to your sacral segments. So these are the different techniques of labor analgesia. Some are non-pharmacological, then your pharmacological and your regional anesthesia techniques. So among the non-pharmacological techniques, first we have the TENS, that is transcutaneous elective nerve stimulations. The first one is there. We have a paddles which has to be placed in the different areas of the back. While stimulating an electrical stimulus is put over there, this causes a diversion of the pain. The other technique might be a relaxation and breathing techniques. So if you take a deep breath during or a labor, it helps in reducing the pain. Next is your by temperature modulations like placing hot and cold packs over the pain areas. It also helps in reducing a pain. Then other is water immersion techniques. The mother itself is put into a hot water bath, which helps in reducing that pain. Then other things like acupunctures. Acupuncture is we have to place a multiple needles over the back of the patients. And again, that feasibility and the procedure is questionable during a labor. Then other techniques like massages, hypnosis and aromatherapies are there. And some of the promising technique is the intradermal injections. Nothing, we just place a sterile water over the specific points, that is over the posterior superior iliac spine and some points below that. So this again, it will diverts the pain. So we have many number of non-pharmacological techniques. All these techniques may help in reducing the pain, but none of them will provide a complete analgesia for the labor. So what next? So we have a pharmacological techniques. In that we have two routes, either by the inhalation agents or we have an opioids. So among the inhalation agents, have you heard about nitrous oxide, which is a laughing gases? It is a part of an anesthesia. So Entonox is a mixture of the nitrous oxide and oxygen. We use a 50-50 percentage. So it helps in alleviating the pain. It either may be given through a mask like that in the lower picture or directly through the mouthpiece. So the patient can breathe through that. So when the Entonox, that is a laughing gas which enter into the pain, it has an analgesic property. So thereby it helps in reducing the pain. But the problem with this, since it is an anesthetic agent, it causes a drowsiness in the patients. Also it causes nausea and vomiting. And again, this nitrous oxide can affect the greenhouse effect. So it is considered as an environmental pollution. So next available agent is sevoflurane. Again, sevoflurane is used as an in the general anesthesia for induction and maintenance, but for labor analgesia, it used in the percentage of 0.8%. We call it as a Sevox. Again, it has a superior analgesia compared to that of Entonox. Again, the problem with this Sevox is it causes drowsiness and intense sedation in the patient, so that during the second stage of labor, the mother has to push down actively to deliver the baby. So this may hinder that part of the thing. So next we have opioids. So what are the opioids, you know? In the pharmacology you might have known that. So for labor analgesia, they have tried at most all the opioids, but none has given a promising effect, but except the three, like pethidine, fentanyl and remifentanil has been widely used, especially over the low socioeconomic countries like us. So in generally we can see in obstetric department, a pethidine is used in the IM route. Also it can be provided at IV. But the problem with the pethidine is it causes a respiratory depressant effect in the fetus and also causes a beat-to-beat variability of the fetal heart. So then the next promising agent among the opioids is the fentanyl. Higher centers can use a fentanyl wherever its availability is there. Again, it's a short acting. So this can be used as an IV bolus or it can be used as a patient control analgesia. So what is patient control analgesia is? A syringe loaded with the drug is connected to the patient's IV line like that. Then the patient has a pump which has a button into that. So whenever a patient needs analgesia, the patient herself can control the drug. So whenever she needs analgesia, he can press the button and the drug is delivered into her hair. So she herself can manage the pain. So fentanyl, it doesn't have much of the side effects. So this can be used for the labor analgesia. Again, availability is questionable everywhere. Next is a remifentanil. Again, remifentanil is ultra short acting. This can also be used in a patient control analgesia. Like as I previously said, we have to load it and given to the patient itself. They themselves will provide their own analgesia. So if there is any contraindications to regional anesthesia, This fentanyl and remifentanil patient control anesthesia has given a promising effect. So next we go for the regional techniques. Do you know the layers of the spinal cord? Spinal cord is surrounded by your dura, subdura and everything. So what the regional technique says is, if we choose any of the space, that is epidural or spinal or both, we can also choose the spaces and provide analgesia through that. So if we put a epidural means, a catheter is placed over the epidural space and a local anesthesia can be provided, and through that anesthesia and analgesia is maintained through that space. Next we have the spinal. Again, it has a most advantage, but the problem with it, it is a shorter acting. So other option is we have your combined spinal epidural. That means in a same patient, we can both go with the spinal and epidurals. So of all the labor analgesia, epidural is the gold standard for providing adequate labor analgesia. So the less frequently used regional techniques are your paracervical, pudendal blocks and the lumbar sympathectomy. So this is how an epidural will be performed. The patients may either placed in the lateral positions or in the sitting positions, and they have special needles are there through which the epidural space has been identified, and catheter can be placed for the infusions or to provide further drugs. So the drugs we commonly used are local anesthetics. We generally use bupivacaine in a concentration of 0.25. This was traditionally used, which is a higher concentrations. Because of the higher concentration, there have been a lot of side effects. So for the past 2 decades, the concentration has been reduced. So the side effects also has been reduced because of that. And again, they will add some additives so that the side effects of the local anesthetics can be used. So the additives we used here is the fentanyl, that is again an opioid, which is used in a concentration of 1 to 2 mics per ml. So now we have identified the epidural, and we have put the catheter into that, and we have started the drugs. So how do we maintain that epidural? Either traditionally we maintain with an intermittent boluses. That means every 1 hour we can give top up through the catheter, or we can give a continuous infusion through uterus. That is a traditional way. But the recent trends is like, again, it's a patient controlled analgesia, or a computer integrated patient controlled analgesia, or a program intermittent epidural boluses. So like I said in the patient controlled analgesia, again same here. The drug is loaded in the syringe and put into the pump, and side this blue button is handed over to the patients. So this is connected to the epidural of the patients now. So whenever the patient needs analgesia, she can directly press it, and again the drug is delivered into her, and she may get the pain relief. So the advantage, again this technique has an advantage that we have use a lower dose of analgesia, and the quality of analgesia is also superior in that. Next is a program intermittent epidural boluses, like same kind of the previous one, but the difference between the two is, the previous one, the patient has to control their analgesia, but in the program intermittent boluses, it has a fixed and the scheduled interval at which the drug is delivered. So it is a fixed doses, and the drug will be delivered in a scheduled time. But the drug is delivered in a higher pressure in these things. So the drug spread will also be higher inside the space. Next is a computer integrated patient's control analgesia. Like same, that syringe pump is directly connected to a computer. This computer will adjust the drug dosage. Suppose in the previous 1 hour, the patient has a lesser analgesia, means in the next hour, the computer will analyze and increases the doses. Again, if the patient in the previous hour, there will be excess of analgesia, means the computer itself adjusts and it will reduces the dose. So let me see the newer insights or updates about the myths and controversies in the labor analgesia. So always there will be a confusion like timing of the catheter, when to place the catheter, whether in the early stages of labor or in the late stages of labor. So what the recommendation, that means American Society of anesthesia and other guidelines says that maternal request is the indication for providing an analgesia invariable to the type of or stages of labor. And again, Royal College of Anesthetists recommend whenever a patients need an anesthesia, it have to be provided not more than 30 minutes. So again, we always have a myth like epidural, especially among the OGs, they may think that epidural, will it increases the rate of cesarean delivery or it will increases the instrumental delivery? The answer is no, because earlier days we used a higher concentration of local anesthetics, so that's why the complications like cesarean section has occurred, but nowadays we reduces the concentrations, so the relationship between the cesarean section, instrument delivery and your epidural is no. Then we trend to withhold the labor analgesia, especially over the late stages of the labor, that is second stages of the labor. They may think that it may cause us complications. Again, they found that it won't cause us any complications. And again, further, if we stop that labor analgesia, especially at the second stage, it will deteriorate the patient's pain rather than it causing an advantage. So the epidural has to be continued throughout the stages of anesthesia. Then they always have a myth like epidural or spinal anesthesia can cause a prolonged back pain. Again, the answer is no, because a lot of studies has been available and they found that there is no relationship between your backache and your epidurals. Nowadays, especially when a patient is coming with the obese or with having an abnormal spinal anatomy like a scoliosis, we may find difficult to identify the place. So this ultrasound guided nowadays is promising for our anesthesiologists. It helps in identifying the intervertebral spaces. It also helps to locate the distance of the epidural space from the skin to the thing. This is one among the newer trends in anesthesia. And again, nowadays we have some newer adjuvant drugs are there which helps to reduce the local anesthetic toxicities. So some of them are alpha-2 agonist and neostigmine. Again, they also helps in reducing, and they have an upcoming promising in anesthesia also. So take-home message is, there are a lot of myths about anesthesia and your labor. So none is true. Anesthesia is safer during a labor, and choose the anesthesia according to the patients and according to the availability of the things. Thank you.
Thank you, ma'am, for gifting us the knowledge that eases the pain of many mothers and creating a deeper understanding of empowering birth with modern relief.
I request our chairperson, Dr. Kavita ma'am, to offer her thoughts.
Thank you, madam, for breaking all the controversies of each obstetrician's mind. And thank you for the informative session. Any questions from the audience?
Labor analgesia is a very important practical topic. Actually, pain in labor is very crucial. So to relieve the pain during first stage and second stage will get a great relief to the motherhood and the relatives. At the same time, we have to maintain the effective analgesia and safety of the patient with recent analgesics and patient-controlled epidural anesthesia, like madam said. Thank you everyone.
Thank you, sir, and thank you, ma'am, for sharing your thoughts. Now I invite Dr. Sridharan, sir, to kindly felicitate our speaker and honor her for her remarkable contribution to this session.